And we are live. Good morning to everyone who is following us from the different social platform that we are streaming on. This is the second appointment promoted by the International Coronary Congress for a live talk with the authors. It's a pleasure to be here. International Coronary Congress wants to move a step ahead of the educational platform, not only an annual meeting that this year will be held in New York City, but also a different setting with a monthly appointment where we can discuss the most important paper or the most important nuances in coronary artery surgery to maintain the education alive and up to date constantly throughout the years. The second appointment of this week will host a discussion on skeletonized versus pedicled internal mammary artery graft harvesting in coronary artery bypass grafting. This is a conversation that comes from a paper published on JAMA Cardiologist on a post-hoc analysis from the COMPASS trial. Today, we host the first author of this paper, André Lamy from McMaster University in Hamilton, Ontario, and we will discuss the paper with Dr. John Pascas from Mount Sinai Hospital, New York City, Dr. David Taggart from Oxford University in United Kingdom, Dr. Mario Gaudino from Weill Cornell in New York City, Dr. Teresa Kaiser from University of Calgary, and Dr. David Gleaner from the University of Ottawa. My name is Gianluca Torregrossa. I'm from Lankenau Heart Institute, and I will be here to help in the moderation and filtrate every question that you guys have. Please feel free to tell us where are you from and tell us also any of your question using the social media comment edits. So, André, please, the floor is yours. And you can start introducing the paper. Tell us about it, why you guys have thought about this type of paper, and what were the findings.
Well, thank you. Good morning, everyone. So the skeletonized versus pedicled IMA, Lima or Lita paper. So first of all, there's a story behind this. It's the COMPASS trial. So the COMPASS trial was testing rivaroxaban and aspirin in a patient with vascular disease. So it was a huge trial. It was sponsored by Bayer, 27,000 patients worldwide, 600 sites. It was hosted at PHRI and Hamilton, McMaster University. And the trial was widely positive. And actually, unfortunately, it was so positive that the follow-up of the trial was stopped early by the DSMB. I mean, it's been published in New England, and you can read all about the trial. Nested into that trial, I was able to recruit about 1,400 patients post-CABG surgery, and they were randomized into the trial. So aspirin alone, rivaroxaban plus 2.5 BID plus aspirin, and rivaroxaban 5 milligrams with no aspirin. And we parted that trial, and we published the results, and there was no difference in graft patency within the three groups. So we published in JACC maybe about 2 years ago. And with the CRF, I had a little space in the CRF that they gave me, and I asked a few questions. And one of that question is if the IMA was done pedicled or skeletonized, because I always has that feeling that there was something there. I have one of my former colleague that was skeletonizing her IMAs, and once in a while she'd start to swear about those. So I put that little question in there, and I put also a question about the vein harvesting technique and the arterectomy. So after the data was published, the study was closed, we started looking at that, and we actually look at the results, and one of my new residents started digging into this. So it is a post-hoc analysis for sure. And we look at the results, and we found that there's an issue there. So out of these 1,448 patients, if you exclude those who had no CTA, so the follow-up was done by CT angiography, and also people who got a coronary angiogram, also we collected that data. And if you exclude the patient who did not receive IMAs, we got about 1,000 patients with IMA, and they're roughly 300. Well, I got 345 and 764 patients, and we look at the patency of these IMA. I guess next slide, if you have that, Gianluca. Okay, so busy. Well, that's for the paper. It's a busy slide. So if we look at the primary outcome with the graft occlusion for the IMA, so the patient who had a skeletonized IMA had a graft occlusion of 9.6%, and those who had Pedicled at 3.9%. And well, the odd ratio is 2.4, and the p-value is 0.002. So it was highly significant. And of course, we did multiple analysis before that. I mean, we look at the veins, we look at the IMA, the lima, the reta, we look at all of those things. But basically, at the end, if we specifically looked at what I think is the most important thing is the lima to the LAD, because that graph is why we're still working. Otherwise, it would be cardiologists, right? The lima has saved CABG surgery over all these stents. So that's the most important graph. And just specifically for the lima, we see exactly the same thing. I got 7.3% versus 3.4%, also highly statistically significant. So there's obviously a problem with the skeletonization of the lima versus the pedicled. So why people skeletonize the IMA? I mean, I don't. So people who do, please let me know. I suspect it's because you want less infection, you want longer grafts, probably better flow. But there's obviously an issue related to that. And so we decided to publish that. But also, if we were looking at MACE, so mortality, stroke, MIs, and revascularization. And the MACE turned out to be positive, but it's mostly driven by revascularization, PCI, and stroke. So there's a bit of chance in there. I can tell you the difference in stroke is not related to patency of this graft. It was small number. It's only by chance. But if you look at the revascularization, you can see right in front of you. It's just, I mean, you can see the curve. Sorry, I'm just going on the other computer. You can see the curve are splitting within a few months, and this seems to stabilize about 2 years after the surgery. So we have the same graphs, the same biology, but they don't behave the same way. So something is going on, and that's why we decided to publish, so that we can look at this more carefully, because it's an issue. Now, I'm participating in the Roma trial from Mario and Steve Freems, and that's a very important impact for the trial, because I suspect that's what happened in ART. I suspect that it could be that the people using skeletonized IMA in ART may have influenced the results of ART. We don't know. We'll never know. We don't have patency results really in ART. And we don't have that in Roma as well. So I'm actually working to get funding to get patency study in Roma. So hopefully it will work. So basically, in conclusion, very important point I wanted to mention. So that study it's not a randomized, it's a postdoc nested within a large trial. But what you have to understand of COMPASS is that we had about 600 sites worldwide. And all these sites are academic, like they randomize patients for a very large trial. So it has to be done in academic centers. And the surgery was likely done in academic centers. Not all 600 sites participated, of course, and I think we got about 75 sites. But these are all academic centers, and it reflects, what's most important to me is that it reflects the overall performance of cardiac surgeons around the world. So it's not an issue of one center, an expert or this or that, or a very tight randomized trial. No, this is what's going on in the world right now. And this is what's worrisome. So that's why we published the paper. I think I can stop here and get your questions.
That's great, Andre. Thank you so much for presenting these findings, and we want to start a conversation that wants to be a very friendly conversation on a Saturday morning, where we can all learn what is the best next step to do. Before starting, very, very quickly, I would like to have a super short answer from each one of you. We start with Mario, just because he's on beside me on the screen here on sharing. Mario, on your last CABG this week, did you skeletonize or pedicle your IMA?
I have always skeletonized mammary all my career. I think I harvested a couple of pedicled mammary when I was a resident, and then it has always been skeletonized.
Good. Andre, you told us you never skeletonized, and so I bet your last CABG this week was a pedicle, correct?
Right.
Perfect. Dr. Pascas, pedicle or skeletonize on your last CABG this week?
Yeah, our default operation is a no aortic touch all arterial bypass based on 2 skeletonized mammaries. That's the last half dozen coronaries I've done have all been that way.
Dr. Gliner, David. Sorry, you are muted. I am mute you, please.
Yeah,
David.
same thing that John. Non-touch aortic technique, skeletonized, mammary, radial, gastro. I never pedicled anything.
Teresa.
I skeletonized for 21 years and pedicled for 12 previous.
Dr. Taggart.
Thank you, Gianluca, and apologies to everyone. I had trouble logging in for some reason, but finally corrected it. So I always have skeletonized. We have done that in Oxford for well over 20 years. And I think it's important to understand there is a rationale for skeletonization. It's not simply saying, do I skeletonize or do I do pedicle? The reason for skeletonization is it gives you a longer, wider graft that makes it easier to do the anastomosis, and especially if you're doing composite or sequential grafts. And the second thing is there's very good evidence that it reduces the risk of sternal wound infection. So I think it's very important to understand there is a rationale for why we say, do we skeletonize or pedicle? And I think, I mean, it's important. I would also congratulate Andre and his colleagues on what is a potentially really, really very important study. But my own suspicion is that this will come down to surgeon experience in who's doing the skeletonization or the pedicled harvest. There is no question skeletonization is technically a bit more demanding until you learn how to do it. And in our center, almost 95% of all ITA harvesting is done by our trainees. So I think that's a very important issue, is who harvested the graft, because is there a learning curve to skeletonization? Yes. The second issue I think that's very important when you look at Andre's study, and again, congratulations, is that the number of skeletonized grafts was far lower at 340 than pedicle grafts at over 760 to the IMA. And that's already telling me there were less experienced people doing skeletonization. And that's also backed up by the enormous difference in both the use and the patency of the right ITA graft in this study. If you look at the outcomes of the ITA in Compass, it was a very low number of ITA grafts, and they had a far higher rate of occlusion than the ITA to the LAD, the left ITA to the LAD. Now, there is no biological explanation to explain why the right ITA should have a lower patency when placed to the LAD than the left ITA. So there's something else happening. And I think you're told what it is when you look at the numbers. I think the numbers are very low for right ITA grafts. And I come back to the same for skeletonization versus pedicled. For the ITA to the LAD, it was much lower in the skeletonized group. So again, I think what Andre's done is extremely important. It's a very, very important study, but these would be my cautions, because I cannot understand any biological reason why a properly harvested skeletonized ITA graft should give inferior results over the short term. Thank you.
That was a short comment. Thank you, David.
Sorry.
All right.
Andre,
Can I answer that?
Go for it. Of course.
Okay, I didn't take any notes, but
your prime time. Go.
So you have to remember this is the world experience. So these surgeons are academic surgeons, whatever they are. They're academic surgeons. So they're not beginners. They're not people who learn a new technique, like when we had it in the past with the off-pump technique. These are surgeons who just did the regular stuff. They didn't even know, most of them didn't even know their patient was on the trial. So that's very important to consider. There's something we could not publish. So the good point, David, is that we don't know about the experience of the patient, of the surgeons. Although, as I mentioned, we expect that they are experienced surgeons because they're coming from academic centers. So we will look at the data by region. If there are low users or high users. So the low users are North America and China. And the high users of the skeletonization are South America and Europe. So you would expect that a low user results would be worse, correct? Totally wrong. The low user actually had the same result pedicled and skeletonized. Is the high user, and we go by region because I don't have nothing else, is the high user have a big difference. So basically people who use it the most getting the worst results. And that's very surprising. And I didn't have data by center, so I could not analyze it. I could not publish it, but that's basically what we found. So it is what it is. I think the more you use it, the more damage you have, because you probably force yourself to make it happen because that's your routine. So that's my point. So that's why I think it's unfortunately we cannot publish that, but it's there. The more you use, or the region of the world that seems to be regional, actually, it's the region who use the most have the worst results.
Gianluca, can I make another quick comment, or have I?
A quick one.
Yeah.
Okay, two things. Mario has repeatedly published studies showing the importance of surgeon experience. And if you look in the ART trial, the crossover from bilateral to single ITA grafts was overall 14%, but varying from 0 to 100% per surgeon. In my own hands, of over 440 ITAs, it was a 1.2% crossover. So if Andre's now genuinely, now the data wasn't in the manuscript, but if it really is the case that the worst outcomes for skeletonized grafts were in the highest users, then that's even more worrying.
Mm-hmm.
Let me ask, I'd like to make a couple of comments. First, I think the driver for skeletonization clearly is the epidemic of diabetes and obesity and the fear of deep sternal wound infection. The desire to do double mammary grafting with the advantage ultimately of a no aortic touch technique in the diabetic on a routine basis has driven me and many others, I think, to a routine double mammary skeletonized harvest as a default operation. Now, either the skeletonized mammary, if harvested perfectly, is as good or better or not as good as a pedicled mammary. One of those things is true. And I'd like David Glenor to comment on the evidence for the biologic basis to make a statement, as he has in the past, that a skeletonized mammary is better than a pedicled mammary. But the second issue is also important, and that is the one raised by David Taggart, and that is experience in harvesting. I have been dismayed to see how hard it is to teach residents to safely harvest skeletonized mammaries on a routine basis. And I've heard Teresa Kaiser, who's also on our call, one of the most experienced double mammary harvesters on the planet, say that she harvests her own because she's fed up with having buggered mammaries at the beginning of an operation. So I think that the difficulty of safely harvesting routine double mammaries has probably been underestimated by many. And perhaps in those centers that use it most routinely, their junior residents are doing it and perhaps not doing it so well. Perhaps that's the explanation for the finding that Andre described. I have, had more than a handful of unpleasant mornings or afternoons trying to put skeletonized mammaries back together in some configuration that allows me to achieve the operation I'd set out to perform. So then I'd like to ask Andre, Andre, do we have any sense from these data whether failed mammary grafts are more common in women or small people than in larger or male patients? Because, there are some little Asian women, for instance, in whom the internal mammary artery can be a very small structure, and harvesting it in an atraumatic way requires genuine technical skill. Whereas, the 250-pound Caucasian truck driver has a mammary artery the size of your little finger, and it's easy to harvest.
Yeah.
So, maybe what granularity do you have in your database, Andre? And can you help us understand which mammaries failed and which succeeded?
Very little granularity, unfortunately. There's less than 20% of the participants that were females. We didn't look into that, or maybe we did somewhere, but it didn't strike any differences. But I will leave the microphone to Teresa to explain, because Teresa was actually part of the trial. I think she recruited 7 or 8 patients in the trial, and I must say that all their lima were perfectly patent. So Teresa, please go ahead.
I'm not surprised to hear that.
Yeah, I think she has a few tricks. Teresa?
You didn't say anything else, Andre.
Yeah. Please, Teresa, you're unmuted.
Thank you, Andre. Am I muted or you got
No,
me?
no, go ahead.
Okay, thank you, Andre. Just as per John's comment, I do teach internal mammary artery harvesting, but I am right beside the resident. I see every stroke until I am comfortable. It's very, very tough, and we don't always have resin, so I do most of my own internal mammary harvesting. But I have one concern. When you hear talks given on skeletonization, invariably somebody in the audience will stand up and say, I use low-dose cautery, and it works just as fast as what you do with your harmonic scalpel. And I shudder inside because the depth of penetration, which is the coagulation depth of cautery, is 1 millimeter is instantaneous. And for harmonic scalpel, it takes several seconds. And the lateral thermal spread is 1/10. Now, even if you use low-dose cautery, I think it may it's just a thought. I don't know. It's going to need some studies. If you use low-dose cautery, you are actually damaging the mammary artery, and it's not going to happen right away. There's going to be some time for that thermal injury to fibrose. What do people think about that? You're muted, John.
David, tell us what is your thinking? What is your personal taking-home message? What do you think? And the comment that Teresa was just pointing it out, it is actually very interesting. Please.
So for sure, I definitely agree with Teresa. I think that the meticulosity that you put into the mammary harvest is critical. And there is no doubt that experience will give you much better, less traumatized mammaries than for the first time harvest with a young resident. To respond to John's comment, yes, we studied the difference between skeletonized versus pedicled mammary nitric oxide production, and we could not find any difference. We used the substance P, which is a endothelium-derived NO production stimulator, and we did not find any difference between the right mammary used in a skeletonized manner and the left mammary used in a pedicled manner in the way how the mammary dilates with that substance P at different concentration. And with at the last step of the trial, we used NO, like what they use in the cath lab, and there was also no difference in the extent of vasodilatation of the skeletonized versus pedicled mammary. So in our trial, there was no drawback of skeletonizing the mammaries. A general comment, what I would say is what David has found in our trial with the experience of the surgeon. I think that we are definitely going towards a world where we should highly specialize our cardiac surgery care, and coronary surgery is becoming a subspecialization, just as mitral valve surgery, TAVI, heart failure, or arch surgery. I think that if you want to be able to do multiple arterial grafting, non-touch aortic technique, minimal invasive, MVST, SVST, you need to specialize yourself into the coronary world, and this will bring much better results than what I usually hear, which is coronary surgery is the bread and butter of everybody's everyday intervention, because still thinking that it's everyday bread and butter doesn't lead to excellence and excellence in the results, in patency. So in my view, coronary surgery should be much more specialized than what it is today. And if you want to achieve the best results, you need to be focusing on that specific topic.
Absolutely. I think this is a very good point, David. Dr. Taggart, I will let you speak in a second, but I just want Mario to give me a very quick point. So let's try to, we are all here seems very positive about skeletonization. But in one way, we have this data, and these data are there, are present. And there is another data that is interesting, is the fact that we start to move away, or we have more solid data about the fact that vein harvesting, so let's move away from mammary, but in vein harvesting, it seems that there's more solid data indicated that if we don't skeletonize them, if we don't take them out as a single vein, but with a little pedicle, is what we call no-touch vein harvest, the outcomes or the patency of this vein, it lasts longer, or it's better. So it's potentially biological, despite what David was just saying. Biologically would make sense. You leave the mammary fed by the two veins, the nerves, the fascia, they could contribute. So what is your position about that? You read a paper like this, what is your gut feeling about the paper? Should we change what we are doing? Should we take it into consideration? What we should do now? We have this data, we have this body of evidence. Should we just say, no, it's just a post-hoc analysis? What's your taking home message here?
Thank you, Gianluca. Well, first time I read Andre's paper, and I read it before it was published, I felt very uncomfortable, to be honest with you, because I have been skeletonized mammary all my life, and I want my resident to skeletonize mammary. But I don't think as a scientist, even though probably scientist is too much for what we do in clinical research, but as someone that like research, I don't think that's the right approach. I think Andre's data share the limitation of all post-hoc analysis. That's true. Numbers are small. The trial was not designed to test these different. That's all true. On the other hand, it's a large RCT with prospectively collected data and with a per protocol angiographic follow-up that nowadays it's almost impossible. So those are data that have a high quality data. There may be, and for sure there are confounders, but we cannot just deny that they are there just because we don't like them. So that would be my first point. Like you say, there may be a biologic rationale. The no-touch saphenous vein, which one can say is very similar to the harvested, to the pedicled ITA, does better than the traditional saphenous vein. Like David Glinell, we published some study looking at endothelial function of the two arteries. We found no difference. The patency rate was not different, but they were small study and single center study. So maybe experience, maybe underpowered. The bottom line, Gianluca, is that this is a very important point, and we definitely need to look into that. It's, if you read the paper, which I find very balanced, Andre doesn't say we should stop skeletonizing the ITA. He just say we need more data on it. And I totally agree on that. We definitely need more data. In the meantime, I think this is a very healthy reminder that harvesting of the conduit is probably the most important part of the operation. And we can't just have the less experienced surgeon and the team doing it. In Roma, our crossover rate is very, very low. It's well below 2%, but we obsessively collected the reason for crossover. And by far the most common reason for crossover is, quote, bad quality of the conduit, which is a nice way to say I screw up the mammary during harvesting. So I think as a community, probably, there are two key messages from Andre's paper. First, we need to look into that more in details. We cannot, maybe we got the old skeletonization things wrong. We are not saying that, but we should look into that. Second, we should really pay much more attention to conduit harvesting, because in the end, this is the most important part of the operation. Thank you.
Thank you, Mario. Dr. Taggart, you were trying to say something, then Dr. Pascas wants also to make some comment.
Great. I mean, absolutely fascinating conversation. So it really is great. And again, let me congratulate Andre on his study. But what we didn't talk about, which I think is absolutely crucial before we move on to the potential biological explanation, is was there any data on TTFM measurements on graft patency before the patients left the operating room? Because one thing we insist on, and I have a conflict of interest here. I work as an advisor to Medistim, so that's my conflict of interest. I'm an absolutely great believer that you need to check your ITA graft is patent before you leave the operating room. If the only intervention in coronary artery disease that makes a difference is having a patent ITA to the LAD. So to me, it's crucial that before the patient leaves the operating room that you've checked that. So I'd like Andre, please, to address that. And the second issue I would say is, in terms of the no-touch harvesting technique, this is a very, very important issue for radial arteries, for saphenous vein, but I don't think it's the same for the ITA graft, because the ITA graft is absolutely unique in that it's the only arterial graft in the body that mainly gets nutritional supply directly from the lumen. So it's not dependent on adventitial vessels the way the saphenous vein graft is, and to a lesser extent, the radial artery. Thank you.
Thank you so much, Dr. Taggart. Dr. John Pascas, you are muted, and I'm unmute you right now. Please.
You know, I think that, as I've said in many other occasions, even as applied to different topics like off-pump bypass, it matters not just what you do, but how you do it. The technique of off-pump bypass makes a difference between a great operation and an operation that's not as good as a well-performed on-pump operation. Everything we've learned about conduits would suggest that endothelial injury, that is transmural injury to the trauma, to the conduit, to the point where the endothelial lining is damaged, that predisposes to early thrombosis or later fibrosis and graft failure. You know, I suspect in my heart of hearts that a perfectly harvested skeletonized mammary is in fact better than a perfectly harvested pedicled mammary for length and flow and reduction of deep sternal wound infection. But an imperfectly harvested skeletonized mammary is clearly not as good as a perfectly harvested pedicled mammary. You know, it's like an arterial graft is better than a vein graft, unless it isn't, right? A great radial artery is better than a bad vein, but a bad radial artery is not as good as a good vein. Even Mario would agree with that, the radial artery aficionado. So, you know, I think it's really crucial that we achieve what we set out to provide for each patient. And then that gets us to the more nuanced idea of which patients should we decrease our expectation for? Are there some internal mammaries that are better off harvested as a narrow pedicle for safety's sake than as a skeletonized graft. And finally, you know, coronary bypass surgery is a two-step operation. Graft harvest and graft deployment. Those are the two steps of every coronary bypass operation. And if you bugger up the first one, it doesn't matter how well you do the second one.
Excellent comment. And we are having a lot of comments coming from everyone who is looking us through the various social media that are completely in line with our conversation. So, Andre, tell us a little bit more about your thinking at this point. You collected this data. This data has been discussed. There's been a very active discussion around this data, both in meetings as well as I was following on social media, on Twitter. There was a huge post about the results of this trial. So now we have collected this unique information, what we can do next and what you are planning to do next, because now somehow we are a little bit in your hand in terms of looking the future.
Thank you. Just to answer David Taggart's question, no, we do not collect any information about the grafts, the flow and things like that. No, we have nothing of that. The trial was not designed for that. Now, the point everybody is saying is that it's important that the skeletonization was well done, and I'm doing great, but nobody seems to do it as great as me. I mean, I can read the comments coming, and well, everybody thinks that they're greatest, and it's possible. But the issue is there's only 1 or 2 surgeons in each country who can do that surgery properly. Well, I would say that's crap. Get rid of that surgery, because tons of people, millions of people are done with regular surgeons like me. So before we can put forward that skeletonization is great, that it doubles skeletonized IMA, no touch is great, I would say, well, prove it, guys. Come on, prove it. So not easy trials to do, but David and I did off-pump trials in the past. They were not easy to do. So I have the feeling in the back of my brain that you're probably right, but I want you to show it. So I would say to the cardiac surgery community and those who are listening to us, like, let's do these trials and prove our points. That's why cardiology actually are eating us, is because they've done so many trials that actually they add up the truth, as you said, John, or the evidence with time, so they can build on that. And unfortunately, cardiac surgery seems to have a problem to do that. So hopefully the Roma trial, which is a big trial going on right now, hopefully we'll be able to get the money, raise the money, and do a patency study from the Roma that would give us, I think, a lot of answers to all the questions discussed today. And there's one thing that I was surprised, and I remember Teresa told me that a couple of years ago, and since then I became the program director of my site. But to teach a resident to dissect the lima, even Pedicled, it's not easy. It seems to be one of the toughest things for a resident to learn, and I'm wondering if they're just too young to learn it. In the sense that, to me, the first thing they do, they learn to cut the skin, then they learn to open the chest, and then they learn to do the mammary, and after that they learn to cannulate, and then they do the proximal and then the distals. Maybe the lima is not in the right sequence there. So I would like to have your opinion on that.
Very good question. Very good point. Very good point, Andre. David, actually, Teresa, tell us your point about this last comment. I want
to suggest, what do people think of a very basic, simple study to start with, and that is a poll of every surgeon you can manage to get the opinion of how they actually harvest. There are 3 different techniques, in my opinion. There's the pedicle, there's the skeletonization with, I watched this before, the skeletonization with the cautery tip as a dissector, there's the skeletonization with cautery low power, and the harmonic scalpel. First, find out, who does, like, how many do skeletonization, because this was like 20% of the surgeons, and then just find out how many are in each category. And this might just set the stage for the next level of study. What do you think?
Just a piece of data. Teresa, you are the only surgeons in the Compass to use your dissector, the ultrasonic dissector. Everybody else is using cautery. And you had perfect results. I must add again.
Okay, thank you.
But I support Teresa, and I say that we should teach more people how to use the harmonic scalpel. I learned when I was working with Dr. Pascas. I love it. I think it's a great tool that allows to simplify the skeletonization and to make sure that the mammary doesn't get injury. For a moment, when I was at University of Chicago, there was no blade available to use an harmonic scalpel, and I went back to Skeletonized with low power cautery and clips, and I personally felt that my mammary were different. They came out soon after the skeletonization, were more spastic than when I take them with an harmonic scalpel. So there is a difference in the way, and for sure there is a technical element. David, I wanted to give you the microphone because to what Andre was saying is actually of extreme interest for me. Cardiac surgery in the recent year, every time we have tried what we have believed in a trial, somehow we lost. And, you know, it's kind of disappointing to be a young cardiothoracic surgeon in the current era because it almost seems that we are lacking evidence or solid evidence of what we are doing on an every basis.
Okay, look, wait a second. That's totally wrong.
Tell me, Mario. Tell me.
There is no win and loss in a trial. Nobody loses the trial. The trial is made to show evidence. So we didn't win, we didn't lose. So this is the wrong approach to the problem. It's an obvious bias. We are just looking for the truth. So I think we should do trial, but I don't think we should do trial to prove something. We should do trial to understand what is the truth.
Very, very good point. And I take it, and thank you, Mario. This is an excellent point. But on the other side, like on all of the randomized trials that have recently happened, I mean, it seems that there is this confounding elements of the things that we have always learned has to be truth. So, and it's very interesting. Maybe there is something about what we have learned that we need to shift in the way in which we are approaching it. David, what do you think, and how do you take now this data about the skeletonization? Does that change your practice? What you will do on Monday? What we will think about it? David, I think you're muted. Yeah, please.
I don't know which David you're talking to, but if you're talking to me,
yeah, sorry.
Well, as I said, I mean, we've published so many trials with patency result with skeletonization, showing that the patency of the mammary is not different in our hands with skeletonization versus pedicled. I mean, I've published 2,000 patients with systematic control, and I didn't see any difference with skeletonization versus pedicled. So in my hand, not my hands, but in my center's hands in Brussels and after in Bruges, and now in Ottawa, I didn't see any difference. Just one comment about the future trial, looking between skeletonization versus pedicled, or in general about patency. I think that it is crucial that we obtain regular angiograms. I don't think that CT scan in the arterial world is accurate. And there is a lot of data in the literature showing that CT scan with vein patency works perfectly well. But CT scans with arteries is not accurate. Why isn't it accurate? Because as soon as you have competition flow in an arterial graft, the CT scan will answer that the graft is occluded. And I had that many, many times. And then you go to the regular angiogram, and then suddenly the graft is open, but there is competition flow. And that's true for the left mammary to LAD, but that's even more true when you start to do what John and many of us are doing, non-touch aortic technique with sequential grafting. Because in that specific scenario, you have much more chance to have competition flow, and even worse, reverse flow from native coronary artery that are not enough narrowed. And so I would raise a lot of concerns about patency and CT scans for arterial grafting. I personally don't think that it's accurate at all. Veins, no problem. Arteries, be careful.
But David, is there any reason to believe that a pedicled mammary artery would be better demonstrated to be patent by a CT angiogram than a skeletonized mammary artery? I mean, I agree with you. I think CTA is a poor second choice compared to conventional coronary angiography to document arterial graft patency, and for all the reasons that you've said. But would there be a reason to believe that that's different for skeletonized versus pedicled?
I don't think so. Personally, I don't have any data, but I don't think so.
Yeah, I'm not sure.
Dr. Taggart, please.
Yeah, thank you. And I was muted earlier. So I think I'll try and keep this brief. So to come back to the points Mario Godino made about randomized trials, this is absolutely crucial. We're trying to improve quality of evidence. The obvious logistic difficulty is there's an enormous difference doing a randomized trial where you randomize a patient to a red tablet or a blue tablet versus where you're randomizing patients to complex technical interventions where there is no evidence that the surgeon is actually qualified to do it. And we saw this in the ART trial with the 14% crossover. And
in the Ruby trial.
And in Ruby. And per individual surgeon, it varied from 0 to 100%. Yet we were still called randomized patients. And one of the strengths of the Roma trial is Mario, Steve Freems and the team have made sure that there is some evidence that the surgeons doing the proposed operation can actually do what they're meant to be doing. So that's point number one. I think the second point is one of the things that we have been a bit arrogant about as surgeons is failure to document what we do in the operating room. No cardiologist would dream of putting in a stent without checking the angiographic result, although putting in a stent is 100 times more straightforward than doing a complex arterial graft. Yet most surgeons take the view, why am I not checking this graft? Because I don't need to prove I did a great job. I think Andre's study shows that we do need to prove that we did a great job, which then comes back to Therese's point about harvesting with the harmonic scalpel. Is it possible that even low-grade electrocautery may cause an injury that's not immediately apparent in the operating room, but may play out over the next few days? That's a very important question. So there are unknowns in all of this, but what I do feel is we do not, even with the available technology we have, we're still not doing the operation to the best of our ability. I mean, if I needed a bypass operation, even to the most experienced surgeon, I would say to him, I want you not to tell me you did a great job, but I want you to show me the TTFM flow in my ITA to the LAD, because that's the one intervention that will change my life expectancy over the next 20 years.
That's right.
We have this question from the audience about checking the ITA before surgery. This is, Dr. Taggart, is in the same way part of the discussion you're having. And in one way, it's interesting. I mean, I had a case just this week. I was taking the blood pressure from right and left arm. This is like a standard for me. And it's a very simple thing, but a lot of people don't do it before surgery. And I discovered that one out of the, I don't know, 500 cases that you do consequentially, I had a patient with a 98% stenosis of the left subclavian artery, perfectly fine with peripheral vascular disease, 82 years old, and I ended up not using the left ITA, and I've never guessed, I would have never figured it out. And, this is just a simple habits to take 2 blood pressure before surgery on 2 arms made it simple. But should we check the coronary artery, the LITA that we use before surgery? What do you think about it? Dr. Taggart.
Oh, sorry. Thank you. Yeah, well, to be honest, I guess I'm getting to a stage where I'm getting really very old now as a coronary surgeon. And I grew up doing almost 35 years of harvesting ITA grafts. And to me, when the graft is harvested, two things. The first is watching the flow from it when you open the distal end is a pretty good indicator of have you got decent flow. And the other thing is we've published is, I think, a great way of making sure you've got good ITA flow. There is no question that as soon as you touch an ITA graft, it has some degree of spasm, even if minor. But if once you've harvested skeletonized, you open it, look at the flow, then you clip the end of it, raise the blood pressure to 150 millimeters of mercury for 5 minutes when it's clipped, and you don't need to heparinize. It's the only artery in the body where you don't need to heparinize. You can leave it occluded for an hour and it will not clot. So it's telling you the ITA graft is a different graft. But if after 5 minutes of a blood pressure of 150 millimeters of mercury, normally the artery will have doubled in size and the flow is torrential. So to me, I'm not sure I would want Gianluca to check 500 patients to pick up one possibly wrong measurement or abnormal measurement. So to me, with the techniques that we use, I think they're pretty proven.
Good point, Dr. Pascas.
So Gianluca, let's do a little poll of the group, how they manage or handle the mammary artery after it is harvested. Specifically, what pharmacologic agents do we use? Dr. Torregrosa described checking the blood pressure in both arms. He learned that at our institution because that's a routine workup for every cardiac surgical patient, bilateral arm blood pressures, because it will detect the occasional patient with a subclavian stenosis that needs further evaluation. But how do we harvest the mammary? We do it skeletonized with the harmonic scalpel. We divide it distally. Typically, I will divide it, check the flow, and then instill within it using a silastic olive-tipped needle, a soft needle. We instill within the vessel a mixture of heparin, lidocaine, heparinized blood, and plasmolite. So it's a pH-buffered solution. Goes about 5 cc's or so are injected into the mammary artery, and then it's clipped. And then it's put in a 10 cc syringe in which we call it the jacuzzi, which has the same solution in it. So the artery is dilated both with pharmacologic agents, both internally and externally. And then we open the pericardium or harvest the other mammary or whatever sequence the operation is going to be. And ultimately, when it comes time to use that artery, we've given heparin at that point. We cut the end of the artery off. That artery the flow should hit the knee of the patient. With a blood pressure mean of 80, the flow at the mammary artery should hit the patient's knee. I don't put it in a beaker and measure the flow per minute, but the flow should be unequivocally robust. There shouldn't be any doubt about that. And if it's a knee shot, it's a good artery. Perhaps that's a crude measure, but it works for us.
We go for the roof shot, John.
Andre, what do you do with your mammary? So what do you do? You give heparin when you, first of all, is the mammary is down, like you took out your pedicled and you are ready to detach. Do you give heparin, yes or no, and how much?
I give 5,000 units. Usually it's because the people who take the vein endoscopically don't want to see a full dose of heparin. So I usually give 5,000. Never had any problem with that. Then I clip it. I put in a gauze with capabrin and that's it.
Do you intraluminally?
I'm not sure I get knee shots, but sometimes I got blood in my face once in a while. But they're probably not as distended as those who are skeletonized. They work well.
Yeah.
So just to clarify, we do have the endoscopic harvesters. We give 2,500 units of heparin at the beginning of endoscopic harvest. So the patient is not entirely unheparinized when we're doing the maneuvers I just described with the arterial conduits. And I do think it's critically important for endoscopic vein and probably for endoscopic radial as well that there be some heparin on board. So I fully support what Andre is describing.
Teresa, what do you do with your mammary?
I am, listening to everybody, I'm reminded of what Ottavio Alfieri says. There are many ways to do things. And I don't instrument the mammary at all. I simply wrap it in a papaverin soaked sponge at the end. And that's it. Simple.
Dr. Gliner, David, this is David Gliner, okay? So what do you do with your mammary? You take two of them ready for doing a total arterial. What do you do?
So first of all, during the harvest, I insist that the pressure, the systolic pressure is above 180 millimeters of mercury all the time, because otherwise, specifically, as John said, in small ladies or in Asian patients, you can have a very spastic mammaries. Secondly, I always ask my resident to start at the upper part of the mammary. So the distal part is always done last, because if you start with the distal part, once you finish the upper part, then the distal part is spastic. Third, once the mammary is completely harvested, we spray papaverin with a small needle on the mammary. I try not to inject anything in the mammary because I'm always afraid of dissecting. And then I do what David Taggart taught me many years ago when we were doing the European masterclass. Once the mammary is harvested, we give heparin, and then we clip the end and push the pressure to 150, 160 for 5 minutes. And as John said, often when you cut it, it hits the knee. Yes, I agree with that.
Excellent. Mario, tell us your technique.
So we transect arteries only when veins are out, so full heparinization. I inject papaverin inside the artery using a 22G angiogram. And then I also use a small olive tip needle to inject papaverin subadventitial, so that the artery is dilated from the outside and from the inside. Then I put it in a sponge with papaverin, and I let it in the chest until.
Can I make a
Thank
quick
you.
comment, Jean-Luc, please?
Go,
Yeah.
please.
I think the question of heparinization is really, really important, because if I harvest a left ITA graft and we're not doing an endoscopic vein, the patient gets no heparin. And we harvest the ITA, we divide it, we clip it, we do not give any heparin at all. We then go to the opposite side and take the right ITA. And it's an amazing difference. If you take a right ITA in a patient, in my experience, when you're skeletonizing that, even if the patient's had 2,500 units of heparin, everything bleeds. It's much more easy to create a hematoma. If you're harvesting the right ITA when the patient's got no heparin on board, you don't see that. This is my experience over 20 years. So I wonder whether, part of the problem in some of these studies is that the reason the right ITA has got inferior patency is it's being harvested after some heparinization's been given, and therefore the visualization is not as clean and pure. But certainly for the single ITA or both ITAs, if you've got no heparin on board, you can divide them, clip them for an hour, and they would never clot. And there's no other artery in the body like that.
Very interesting. So we are wrapping up to the end of this conversation, and I would like just to have some taking home message for everyone who have watched us through this live, and whoever will see and maintain will see the recording of this talk about Pedicled versus Skeletonized. So please, all of us, give us a little taking home message. And I do believe also from this conversation, it seems to me that will be very interesting to start to plan a randomized trial, as Andre was suggesting in the conclusion of his own paper? Should we plan for a randomized trial properly focus on this topic? Does that make sense? And if yes, how we should design it, or what is your home message from it? And secondly, what will you do, or what is your taking home message from this paper? How this will change the way in which you are doing your surgery? You might still stay with your own technique, that is skeletonized or pedicled, but how that will change the way in which you are perceiving or you are seeing this skeletonization. And I will start with you, Dr. Taggart, please.
So great questions, Gianluca, and congratulations to you for organizing this talk this morning and for the great stuff Andre's done. I mean, I guess we've all got to think, do we need to go and get a life if on Saturday we're still talking about should we harvest mammary artery by skeletonization or pedicled? But seriously, it's a very, very important question. A trial would be extremely important, but only as long as the surgeons participating have a proven certificate they know what they're doing. Because to me, that's absolutely crucial. The second thing is, despite Andre's study and listening to everything, I have not seen anything that would concern me that somebody who really knows how to harvest a skeletonized mammary artery should change their technique, because there are other benefits, and you have a wider, longer artery with better flow. It makes composite and sequential easier, and it reduces wound infection. So at this point, I've not seen enough to make me think I should change my technique. But thanks for a great session.
Thank you. Dr. Pascas.
You know, I'm going to reiterate a statement I made a little while ago, and that is that every coronary bypass operation is a two-step procedure. It's conduit harvest and conduit deployment. And the second step, the conduit deployment, depends upon having achieved a perfect conduit harvest. So as several of our panelists have stated today, I think that we, as a profession, have probably underestimated the importance of conduit harvest and relegated that or delegated that to the least experienced members of our team. And probably that is a disservice to the field of coronary surgery and to our coronary patients. We need to spend more focus on expert conduit harvest. There are increasing volumes of evidence that would suggest that rough endoscopic harvest of veins, for instance, produces a decrement in graft patency compared to no-touch vein harvest, and that no-touch veins may actually be as good as arteries. This body of evidence from Andre cannot be ignored, as Mario said. You know, these are real-world surgeons. They're choosing to harvest pedicled or skeletonized according to their own belief that they can do it well. It's not randomized. It's post hoc. It's a CT angiogram. There are lots of weaknesses of this data set, but it cannot be ignored. And to me, it re-emphasizes the importance that it's not just a matter of what you do; it's how you do it.
Completely. Dr. Gliner, please, David.
Yes, so as often in surgery, everything comes back to reproducibility. Is one technique reproducible or not, and is it extendable to the complete community or just reserved to a very subset of surgeons? I think that the higher the technicity is, the less likelihood this would be reproducible. Now, when we come back to mammary harvest, it's difficult to say that it has to be just a subset of surgeons doing this, because it's what we do every day. However, I think that if you have a correct training, and if you have you're not rushed by time, with experience and with the correct training, you can definitely achieve a very good harvesting skeletonized of the mammary. And for sure, a trial would be welcome. But once again, as I've already said, I think that regular angiogram should be the tool used to assess the patency afterwards.
Teresa, please, you stood up as one of the not only best skilled surgeon to harvest, but also to teach residents and young surgeon. Give us some of your feedback about this conversation and this article.
Well, first of all, thank you, Andre, for publishing this paper. This has been extremely important. Secondly, Fitzgibbon of the ABO graft classification fame, with whom I worked for 2 years, used to say, if I needed bypass surgery, I would want the surgeon to harvest the conduits and the resident to open the chest. And the last point I would like to say is that the skeletonizing technique compared to the pedicled technique is surgeon dependent more so, and possibly even surgeon variable.
Thank you so much. Completely agree. Mario, give us some of your feedback, and then Andre he has the chance to speak the last in a fairness point. Mario, go ahead.
I think John, as always, was great in saying that the key message for the community at the moment is that we need to pay a lot of attention of conduit harvesting. That may require some change in the way our fellow are trained. I agree with Andre. Andre, probably the sequence that the first thing you do after having learned how to open the sternum is to harvest the most important conduit of the operation. It's not ideal. So we may have to rethink that, even though logistically it makes sense. It may not make a lot of surgical sense. In terms of the next step, I am always fascinated how surgeons takes everything that is related to surgery very personal, and they get so excited about it. And you can read about the internet. Crazy. Or someone is saying that my skeletonized mammary is not as good as the pedicled, but that just because we are so passionate about what we do. But you know, there has been the process of generating new evidence has been around for many decades. So generally, when a post-hoc analysis of an RCT, which by definition is hypothesis generate an hypothesis like here, there should be other hypothesis generating analysis to confirm that the findings that Andre observed were not just due to chance. And then if this is the case, a randomized trial is needed. I don't think, unfortunately, that conventional angiography will be allowed in a trial like that for ethical reason, and also because the patient would be unwilling to undergo coronary angiography for study purpose. But like John said, I don't see any reason why, especially if you focus on the LITA to LAD, you should have a difference in assessment between the two groups. So probably coronary CTA is okay. But the key message is thank you, Andre. We may have underestimated this problem, and your paper is a very important reminder that we should probably look at that more carefully.
Andre, I promised at the early beginning of this conversation, when we were offline, a very friendly Saturday morning chat with a cup of coffee, and just try to educate and try to know, as a passionate and a young passionate in coronary surgery, I just want to learn more. So I hope the final goal was achieved. I don't see blood spread around the screen, so that's already a great success. And I want to leave you the microphone for your last words and taking home message.
Well, thank you. Just a little detail. I disagree with Dr. Glinner about the CTA. I've heard that from two surgeons, and they're both from Ottawa. So I suspect the problem is an Ottawa CT reader. And it could be simple as, you know, in these trials, the description of the conduit is well known to the reader of the CTA. So they know exactly what has been done, which possibly clinically doesn't happen. It was just signed for CTA to the radiologist and say, figure it out. So it might be an explanation. And I agree with Mario that, like in the past, if you go for a coronary angiogram, you get 60% of the patients coming back. If you go for a CTA, you get 80%. It's a big difference. And overall, I agree with all your comments. And finally, I mean, I hope I'm wrong. I mean, if you're a good trial, you prove me wrong, I'll be very happy with that. I mean, all I want is safety for the patients. I mean, it's not a battle. It's like I said before with the coronary trial, the off pump, on pump. It's not to prove that you're right and the other guy is wrong. It's just to improve the safety and the quality of care to the patients. That was the goal of the trial. We can hate the cardiologists, but that's okay. But between us, I mean, we have a great revascularization. It's better than any stenting. 25th generation of stent Lima is still better, and it's going to continue to that. My hope is as a group of coronary artery surgeons, we can actually elevate the field of coronary artery bypass surgery as a subspecialty. It's been said before, and I think that the bypass, which used to been seen as bread and butter for the new surgeon to come and do, well, maybe it's not correct anymore, because these patients have nothing to do with what the patient I had 25 years ago. They're older, they're all diabetic, they're all complex, and nothing to do with when I started my practice. So we somehow, I don't know how, but somehow we can elevate bypass surgery as a subspecialty or super specialty. That would be great. I mean, I look at my colleagues doing valves and they walk in the hospital like gods, but a valve is about that big, while the coronary artery is about the size of my ball pen there. So we're not dealing the same thing. And I think coronary artery bypass surgery is more difficult. It does not forgive. I mean, if you come off pump and one of your grafts is wrong, you're going to pay a patient will pay a big price for that. So my hope was it was a great meeting. So thank you everybody for criticizing me. That was well done. And I agree, you have very good points. The future will tell us what it is. But let's have more trials and find the answers, and let's elevate our subspecialty. Thank you.
This is a fantastic final message. And with this sense and this culture, the International Coronary Congress is promoting these appointments that wants to promote and educate and elevate the coronary surgery culture. So taking the education to the next step, not only one yearly appointment for a meeting, but also as much as we can, a monthly appointment where we can all discuss, we can all educate ourselves, we can all grow and make at the end, as Andre was saying, better outcomes for our patients, because at the bottom line, this is what really matters. I want to remind you, the 7th annual meeting of International Coronary Congress is up and coming in the next December. I want also to remind this is the last weekend to submit your abstract to the International Coronary Congress. So please submit, join, participate in it, and stay tuned. Follow us on YouTube, on LinkedIn, on Twitter to get updates on our next talk that will be in around 30 days from now with a new subject, with a new topic in coronary artery bypass grafting. With this, we want to end this live. I want to thank everyone who participated today. Thank you so much for taking a time on your Saturday morning, and all of you who have followed us and have sent us so many messages from the web. So thank you again, and see you in 30 days. Bye, everyone.
Bye-bye.
Bye.
Bye.
Thanks.